Okay, so my presentation today is covering suction and tracheostomies, and this will be immediately followed by practical demonstrations. Okay, so suction then is defined as the removal of airway secretions by using applied negative pressure. It is performed in a patient who is unable to independently clear the bronchial secretions to maintain a patent airway. Okay, so some of the type of patients then that we would be suctioning would be our intubated and ventilated patients, patients with tracheostomies, the spontaneously breathing patients with sputum retention due to unconsciousness, semi-consciousness, ineffective cough or impaired mucociliary action. So our indications for suction are evidence of sputum retention or excessive secretions that are accessible via a catheter, secretions that are detrimental to the patient, and the patient that's unable to clear secretions by other means. So on this slide, you'll see a list of contraindications and precautions for all the different methods of suction, but it's just important to say that when indicated, there's no absolute contraindication because the decision to abstain from suction in order to avoid a possible adverse reaction may in fact be lethal. Okay, so some of the adverse effects then, it is important to say a good suction technique with low pressures, the smallest appropriate catheter size and selecting the correct route of entry will minimise adverse effects. Okay, so with mucosal trauma then, we can cause mucosal hemorrhage, which can lead to infection and ulceration, pulmonary and intraventricular hemorrhage, suction you can just cause further trauma and bleeding. Pneumothorax or high-risk patients, there would be our COPD patients with large bullae, bronchospasm, atelectasis, infection, increased risk, especially with those patients that have trachea or ET tube. And then with hypoxia and hypoxemia, laryngospasm, which is rare but it's very dangerous. You'll know this if the catheter feels stuck when you go to remove it. If you're in the hospital, it's immediate cardiac arrest call. If you're out in the community, you detach the catheter from the suction tubing and you dial 999. Then with increased ICP, patient distress, and then uncontrolled coughing or stimulation of the gag reflex, which could lead to further aspiration. So we have 6 different types of routes then. So we have our ET tube, we have our tracheostomy, mini tracheostomy, or pharyngeal via an airway, or nasopharyngeal with or without an airway, and we have Yanker suction. Again, we'll cover all of these in the practical element then. So choosing the correct size of catheter or airway, so we're going to look at first our ET tubes, our trachees and our mini trachees. So in order to establish the correct size of catheter, we do the size of the airway -1 times 2. It's important to say there that occasionally necessary to use larger catheter size due to viscosity of secretions, but you should proceed with caution. So our oropharyngeal airways then. So for adults, the most common Guedel airway sizes are green, orange and red. To measure the correct size that we'll need, we measure from the mandibular angle to the lips. Again, we'll demonstrate this in the practical element as well. And the coloured section of your airway should be at the level of the patient's teeth. So our nasopharyngeal catheter then, so the smallest size catheter to be effective. So in a child that's roughly a size 6 or 8, older child will be a 10 and an adult 10 or 12. So the size of the suction catheter should be about half the diameter of the nostril. Okay, so this is quite broad here because again we will go into this individual routes in the practical element. But we insert the catheter into the airway on inspiration. We apply suction only on withdrawal of the catheter. Suction pressure applied should be continuously while withdrawing. Do not rotate or twist the catheter on withdrawal. The duration should be no more than 15 seconds. In an adult, the pressure, maximum pressure is up to 20 kPa. So it's continuous reassessment during the procedure. And there's no definite recommendation about the number of suctions per treatment episode. It is based on clinical need. Time should be allowed between each suction in order to optimise oxygen levels, assess the patient's respiratory symptoms and any hazardous effects, and reassessment as per pre-suction baseline OBS. So on this slide you'll see the APCP guidelines for suction pressures for children. Again, this is just a rough guide and the smallest pressure to be effective should be used. Then just to say about pre and post oxygenation, ensure when suctioning that oxygen is readily available. Suction increases oxygen demands by an average 27%, which may lead to hypoxia. Those are particularly high risk of hypoxia are those requiring oxygen therapy, previous desaturations and impaired respiratory or cardiac function. 100% oxygen should be given to patients with acute head injuries, patients requiring oxygen more than 50%, patients with pulmonary pathology and patients with bradycardia. FiO2 plus 20% should be adequate in most stable patients when the technique is performed quickly, and 10% above patients' baseline for COPD patients to keep their sats within 88 to 92. Reoxygenate following suction. So signs of successful suctioning then: the patient appears more comfortable, ensure the respiratory status is normal, ensure the obs have returned to the baseline values, removal of pulmonary secretions, improved oxygenation sats and/or colour, improved breath sounds and improved auscultation. Okay, so just to say about modifications of treatment then: if your secretions aren't clear, consider increasing your catheter size or increase the pressure, but this should be proceeded with caution. Repeated suction trauma, consider NP airway, try other nostril or decrease your catheter size. So some important points about suction then. So limited evidence with saline irrigation. Consider clinical rationale as to why you want to use. Saline and mucus do not mix, and the saline does not disperse any further than main stem bronchi. Consent is very important. If patient can in any way communicate, informed consents need to be sought. Consent forms to be completed as per CSP guidelines. Always inform patient of proposed procedure, whatever their consciousness level. So the importance of infection control. Hand hygiene is the single most important infection prevention and control measure. So our PPE, clean gloves and disposable aprons should be worn for any suctioning procedure. And then our masks, eye protection and our fit mask for any aerosol generating procedure. And then this slide is just showing some of the community suction devices available. It's actually quick. Okay, so tracheostomies. So a tracheostomy is an opening in the front of the trachea which can be temporary or permanent. It is inserted through a surgical opening known as a stoma. Tracheostomies can either be performed electively or as an emergency procedure in order to keep the airway patent. The larynx. The function of the larynx is to protect the lungs, control airflow and initiate speech. During inspiration, the vocal cords abduct, and during expiration, the vocal cords adduct, although not fully. So the indications for a tracheostomy then: to secure a clear airway, so example in an upper respiratory tract obstruction or following surgery, trauma to head and neck; to facilitate mechanical ventilation and weaning by reducing the patient's work of breathing and aiding removal of bronchial secretions; and to minimise the risk of aspiration in patients who have lost their protective cough, gag and swallow reflexes. So we have 4 different types of tracheostomies. We have the cuffed, uncuffed, fenestrated and unfenestrated, and again these will be shown in the practical demonstration. So you have your cuffed tracheostomy tubes then. It's usually the first tube of choice in the ventilated patient. The cuff maintains a tight seal in the airway, allowing positive pressure to be directed into the lungs. Cuffed tubes, however, limit the ability to speak and swallow, as well as reducing the ability to taste and smell. Then we have our uncuffed tracheostomy tubes. No cuff puts the patient at a greater risk of aspiration and chest complications. Ventilation is less effective due to air leakage around the tube. This free flow of air around the larynx can aid weaning a patient from mechanical ventilation. This ensures they can maintain effective respiratory function prior to decannulation. Useful in patients who have a weak cough reflex but still requiring suction to clear secretions. Then we're fenestrated and unfenestrated tubes. They're often double lumen, and they're useful when patients are weaning from ventilation to progress to breathing normally. Unfenestrated inner tube must be used when suctioning. This prevents suction catheter exiting through the fenestration and damaging the tracheal mucosa. So tracheostomy care. Staff caring for a patient with a tracheostomy should be able to undertake general cares. So general cares include inner tube care, care of the stoma site, tapes and dressing changes. Inner tube is really important that it's checked regularly. Remove inner tube and clean. Crust can obstruct airway and cause distress. Use inner tube cleaners or swabs to clean. Many emergencies can be avoided if the inner tube is kept clean. The importance of humidification for patients with a tracheostomy is well recognised. Poor humidification leads to increased mucus viscosity, decreased ciliary activity, obstruction of the airways, and it may be fatal. Good humidification leads to reduction of pulmonary problems and other physical and psychosocial problems. In normal airways, air is warmed, moistened and filtered as we inhale. 70% of humidification occurs in the nasopharynx, thus mouth breathing is less effective. Humidification is less effective again when bypassing the upper airways. So in this slide, you'll just see a range of the different methods of humidification for tracheostomies, and again, we will show some of these in the practical demonstration. So adjuncts then, we have our heat moisture exchangers, replace some of the functions of the nose, increase temperature of inhaled air, filter the air, reduce sputum production and improve quality of voice. So we have our Passi-Muir valve, allows for voice speech production, improves swallowing, management of secretions, infection control and improved quality of life. And then just to say about laryngectomies, permanent airway in the neck, no ability to breathe through the mouth and nose, limited smell, communication, obviously will be a problem as their larynx has been removed. Importance of keeping stoma clean, importance of using heat and moisture exchangers. We have to suction through the stoma, and the O2 supply is obviously a neck mask. Okay, so this first video we're looking at nasopharyngeal suction. So obviously you've established your need for suction, you have gained informed consent where possible, and you have checked the patient's medical notes. Okay, so prior to going in, you're going to wash your hands and put on your appropriate PPE. You're going to explain to your patient what you're going to do. You're going to position your patient appropriately so their airway is as open as possible with their chin pointing upwards and their head tilted back. You're going to pre-oxygenate your patient for about 2 to 3 minutes prior to your suction, and you are going to check your patient's clinical obs just to make sure they're satisfactory before proceeding with your suction. Okay, so you're going to select your appropriate sized airway, and you're going to insert it into your suction tubing just by opening at the top. Okay. And inserting your upper end into the suction tubing, keeping the rest of the catheter in the plastic sleeve to keep it as clean as possible. You're going to pop that in underneath your arm, and on the inside of the plastic sleeve there, you can add some lubricating jelly just to lubricate the tip of the catheter before you insert it. Okay, at this point then we're going to add our second glove, and this is just for your clean hand, and this is the only hand that should touch the catheter. Okay, so you're going to turn on your suction. Okay, and you're going to slowly remove your plastic sleeve, okay, and making sure your clean hand is the only hand that touches the catheter. And as you come out, you're going to lubricate the tip of your catheter with some gel. Okay. So you're going to explain to your patient that suction is going to occur. You're going to gently insert your catheter tip into the nostril, aiming towards the opposite eye. Okay. If you feel you're getting stuck, you're going to come out ever so slightly and you're going to gently reinsert. Okay. So what you're looking for is the cough. If you're not getting a cough, you'll feel resistance. You come off about 1 centimetre. You apply your suction, and you slowly remove, okay? And once you decide to come out, you shouldn't be going back in and out. Okay, and out you come. And then you're going to wrap your catheter around your dominant hand, pull the lower end of your glove over your catheter, discard of that, reapply your oxygen. You're going to reassess your patient and decide whether you need to repeat your suction again. You're going to flush out your suction tubing, and then you're going to remove your PPE and wash your hands. This video we're looking at oropharyngeal suction via an oral airway. Okay, so again, same principles apply. You've established your need for suction, you check the patient's medical notes, and you've gained informed consent where possible. You've washed your hands and you've put on your appropriate PPE. So you're going to explain to your patient what you intend to do. You're going to position your patient again so their airway is as open as possible, ideally with the chin tilted up. You're going to pre-oxygenate for about 2 to 3 minutes before your suction, and just before your suction you're going to check your clinical obs just to make sure they're satisfactory before proceeding. So the first thing we're going to do is choose an appropriate sized airway. So to do that, you measure from the tip to the end of the airway, and we go from the mandible to the lip. Okay. Okay. And the end of the airway should be in line with the lip. Okay. So again, we're going to insert our airway. So we just open our packet. Okay. And what we're going to do is apply a thin layer of gel on the inside of the packaging just to aid insertion of the airway. Okay, so at this point we're going to insert our airway. Again, just rubbing a thin layer of gel over our airway. Okay, So to insert, we're going to insert with the tip pointing upwards for the first 2/3 of the way in, and then we're going to turn after that point. Okay, so on this model it's a bit harder, but in real situation it will be much easier. Okay, so when we're in about 2/3 of the way in, we're going to turn, and then we're going to, okay. So at this point then you reassure your patient that they can still breathe through the airway. You may need a second person to hold that in place. Okay, so now we're going to choose our appropriate sized airway, and we're going to attach it into our suction tubing. Okay, just by opening again at the top, keeping the rest of the catheter in the plastic sleeve. We're going to insert into our suction tubing. Okay, we're going to pop that in under our arm. Again, you can apply another thin layer of gel on the inside of your plastic sleeve just to aid insertion of the catheter. At this point then we're going to add our second glove, and this is going to be our clean hand and the only hand that touches the catheter. Okay, we're going to turn on our suction, and again we're going to slowly remove our catheter from the sleeve, making sure our clean hand is the only hand that touches the catheter, and as we come out we're going to apply a thin layer of gel over the end of the catheter. Again, we're going to explain to our patient the suction is about to occur, and we're going to slowly insert the catheter into the airway. Again, what we're looking for is a cough or where resistance is felt. If resistance is felt, you come off about 1 centimetre, apply your suction, and you slowly come out, making sure you're getting all secretions as you come out. Okay, so you're going to wrap your catheter around your dominant hand, pull the lower end of your glove over the top of your catheter, and you're going to discard that in the appropriate bin. You're going to remove your airway. Okay, you're going to reattach your oxygen. Okay, and then you're going to reassess your patient and decide whether you need to repeat your suction again. If not, you're going to check their clinical obs are returning to normal. You're going to flush out your suction tubing. You're going to wash out your airway with cold water so that you can use it again. And you're going to remove your PPE and wash your hands. So this video we're looking at suction via tracheostomy, mini tracheostomy, and the same principles will also apply through a laryngeal stoma. Obviously the patient won't have a trachea in place, but the exact same principles apply. Okay, so as previous, you've established your need for suction, you've checked your patient's medical notes, and you've gained informed consent where possible. You've washed your hands and you've put on your appropriate PPE. Again, you're going to explain to your patient what you intend to do. You're going to pre-oxygenate your patient for 2 to 3 minutes prior to your suction. You're going to check the patient's clinical obs prior to proceeding with your suction just to make sure they're satisfactory. Okay, so we're going to choose our appropriate sized catheter. We're going to insert into our suction tubing just by exposing the upper end and attach in, keeping the rest of the catheter in the plastic sleeve to keep it as clean as possible. We're going to pop that in underneath our arm. We're going to apply our second glove, and that's going to be our clean hand and the only hand that touches the catheter. I should say at this point as well, you need to just double check before you suction through a trachea that you have a non-fenestrated inner tube. Okay, so you're going to turn on your suction. Okay, you're going to slowly remove your catheter from the plastic sleeve, making sure your clean hand is the only hand that touches the catheter. Okay, again, you're going to explain to your patient that suction is going to occur. You gently insert your catheter into the trachea, and again, you're going down nice and slowly, and you're looking for that cough or to where resistance is felt. If you feel resistance, come off about 1 centimetre, apply your suction, and slowly remove your catheter. Okay, you're going to wrap your catheter around your dominant hand. You're going to pull your glove over the end of your catheter, and you're going to discard of that. You're going to reapply your oxygen. You're going to reassess your patient again and decide whether you need to repeat your suction or not. If not, you're going to check your patient's clinical obs and make sure they're returning to normal. You're going to flush out your suction tubing, and you're going to remove your PPE and wash your hands. Okay, so this video we're looking at Yanker suction, which is a lot more straightforward, but the same principles still apply, and we're going to use Yanker suction to clear visible secretions from the mouth. You're going to obtain informed consent where possible, and you're going to check the patient's medical notes. You're going to wash your hands and put on your appropriate PPE before coming to the patient. Okay, so you're going to explain to your patient what you're going to do. You're going to check your patient's position in the bed, and you're going to check the patient's clinical observations before proceeding with your suction. Okay. you're going to attach your Yanker catheter to your suction tubing just by opening the lower end of your packaging. Okay, so pulling off the lower green sleeve, keeping the upper part still within the packaging, and you're going to pop in your Yanker catheter there. You're going to apply a thin layer of gel on the inside of the packaging just to aid insertion of the Yanker. You're going to pop that in underneath your arm, and you're going to turn on your suction. Okay, you're going to slowly remove the upper part of your Yanker catheter from the plastic sleeve. Okay, again, you're going to explain to your patient that suction is going to occur. You're going to keep your suction off until you're into the patient's mouth. Okay, so you're going to gently insert the tip, apply your suction, and you're going to remove all visible secretions in the mouth. And as you withdraw, keep your suction on. Okay. And then you're going to discard your Yanker catheter by pulling the lower end of your glove over the Yanker catheter and just discarding of that in the bin. You're going to reattach your oxygen, and you're going to reassess your patient and make sure their clinical obs are returning to normal. You're going to flush out your suction tubing, and you're going to remove your PPE and wash your hands. Okay, so this is just a short video to show you how to attach a sputum trap to your suction if you're requested, if a sample is requested. Okay, it's very easy and straightforward, but it is worthwhile any time before you go in to do a suction on a patient that you check with the medics if a sputum sample is requested. So when you go into the patient's room, make sure you have all your necessary bits and pieces with you, including your sputum trap, your request form, your biohazard label, and any patient labels that you need to take in. Okay, so really there's only one way that this can go. So this end attaches into your suction tubing, okay, and this part goes to your catheter. Okay, and then you just proceed on with your normal suction. Okay, so if after your suction's complete and there's no secretions in your sputum trap, what you're going to need to do is, if there's secretions in the tubing or in the catheter, you're going to want to mobilize that with some sodium chloride. Okay, so what you do, you just open the top of your plastic vial. Okay. Okay, and with your suction, you're going to entrain a small amount of that into your catheter, and that should mobilize the secretions into the trap there. Okay. Once you've got secretions in the trap, then you can finish your suction. Okay. Okay, and you're going to close that over in the patient's room. Still wearing your PPE, you're going to pop that into a bag, and for our COVID-19 patients, we're going to need to double bag that. It's really important when you have finished your suction that you have all the necessary information on the front of your form, or that will not be accepted. Okay, and you need to get that off as soon as possible.